So here I am showing you the surgery phacoemulsification of a very hard cataract. So after peribulbar anesthesia, now making main port with a phaco knife 2.75, and now we are staining the anterior capsule. Now remove the dye and the air bubble with Simcoe cannula. Put viscoelastic. And now the most important step of capsular access. Straight incision in the center. Elevate the flap and now rotate the flap 360 degree. Make sure that it is within the reach of the pupil. So now you can say a round capsular access is made successfully. Now hydrodissection. Now normally I skip this step in a hard cataract, but here the cataract was adherent to the capsule. There was fibrosis as well, so I tried to separate it from the capsule. Now side ports. With 15-degree phaco knife. And now proceeding to the phacoemulsification with 60 phaco power, and I use Tyler as a second instrument. Today I will perform phacoemulsification in the back so that we can protect the corneal endothelium. Now I am making a tunnel. It was a very hard and thick cataract, so it will take a lot of time, but if we perform deep phacoemulsification, we will have a clear cornea on the second day. Now here I am trying to divide the two pieces, but the trench is not deep enough, so I will rotate it and try to make a cross. Now here I am performing vertical chopping, and you can see that I have divided it into two pieces. Now again vertical chopping. In the vertical chopping, you hold the nucleus with a phaco probe, and then with the help of a second instrument you push the nucleus away. Now here I am dividing it into multiple small pieces by vertical chopping. Now again I came out because gel was not in the anterior chamber, so I put viscoelastic, and now again I am trying to create small pieces. Nucleus is very deep, very thick, so I am making small breaks, but they are not deep enough. But still the nucleus is in the bag, so it is a deep manipulation. Pupil is also not very dilated. Again I came out, the anterior chamber got shallow, so putting the gel HPMC 2%. So now half of the nucleus is emulsified, but still, as it was a deep and a thick nucleus, so still we have got half of the posterior cataract left. So we are here, you can see, trying to emulsify and aspirate. Now pupil is gradually constricting, and that's because of the manipulation. Our second instrument is touching the iris again and again, and the iris is a tissue that it gets irritated by touch. Generally, you should avoid touching the iris. Then it will stay in its position, it will be dilated. So now almost 80% of the nucleus is emulsified, you can see, and now the last cortical sheets and posterior nucleus pieces. Now that's a very important step, because your foot pedal comes into play. You should aspirate such that it should be controlled, otherwise you can also rupture the posterior capsule, which is lying just beneath those sheets. And don't move the phaco probe too much away from the center. With the second instrument you can manipulate it. So now very less sheet is left. Again I came out, put viscoelastic, so you can see normally mostly I do the phaco emulsification in a single go, but here, just for the safety of the cornea, to avoid severe striate keratopathy, I performed the phaco emulsification in the bag, and it definitely took more time, but at the end the patient will be happy and the cornea will be clear. So now we are implanting the foldable intraocular lens. The following haptic is outside the bag, so with the help of a dialer I have implanted it successfully in the bag. Now remove the viscoelastic, as there are no lens matter in this hard cataract, but still make sure that you have removed all the lens matter and also remove all the viscoelastic. And now hydration of the side port. And now hydration of the main port. Hydration of the ports is complete when the anterior chamber suddenly deepens. So that will give you the idea. Like here, now the anterior chamber gets deep. Thank you very much.